I'm Roger DeRose. At Kessler Foundation, we're committed to changing the lives of people with disabilities through research and employment strategies. And that's why we're proud to support programming produced by the Caucus Educational Corporation and their partners in public television.
So what exactly is population health? Next on Caucus New Jersey.
Funding for this edition of Caucus New Jersey has been provided by the Robert Wood Johnson Foundation, Wells Fargo, Berkeley College, PSE&G, committed to improving New Jersey's economy and strengthening its communities, MD Advantage Insurance Company of New Jersey, the Mental Health Association in New Jersey, and by Steve and Elaine Pozicki. Promotional support provided by NJ.com, Small News, Big News, True Jersey, and by Commerce Magazine.
Welcome to Caucus New Jersey. I'm Steve Adubato. You know, healthcare reform encourages new ways to improve our care and reduce hospital visits for those with chronic health problems. Here in the studio to discuss something we call population health and how it impacts all of us, we have Mark Homowicki, General Counsel and Director of External Affairs for the Camden Coalition of Healthcare Providers. Andrew Thomas is Interim Director of Care Transitions and Care Coordination at Robert Wood Johnson University Hospital. Eva Turnbeiner is President and CEO of Zufall Health, and Ephraim Ortiz Colon is a U.S. Army veteran who suffered a heart attack in 2014 and actually served 23 years in the military and enlisted what year?
August 28, 1979, 4:15 p.m.
In the Army?
Yes, sir.
Thank you for all the years you served our country.
It's a pleasure.
I've got to ask you, you know, we're talking about new ways to deal with chronic health problems in the new age of healthcare, but I'm curious about this, Mark. Is it all that different?
I think it is different. I think that traditionally our healthcare system was very much a sick care system. We focused on the person that was suffering from an illness and presented at the hospitals or a doctor's office, and we tried to treat that illness. We weren't as focused on how do we keep people healthy. That was their own individual responsibility. And what we found is that a lot of people are getting sick, and we're spending a lot of money on sick people who could be much healthier. And if we change how we deliver our health care, we can keep people much healthier and save money at the same time.
So let's break this down. The term population health is being used a lot. I'm not a fan of what I call jargon. To me, it sounds a bit jargony. But the question becomes, beyond whatever you call it, what exactly is it? And so people say population health is a way of dealing with a larger community of health. So let's break this down. The argument is that healthcare is, while it's focused on the individual, is now being focused more on the community. How exactly do you do that? In concrete examples, how do you do that?
Delivering health care to a population is really different from delivering to an individual. Now you're looking at things, you're looking at problems that the population have instead of just what the individual has.
Give us an example.
For instance, you can look at health disparity. You can look at, for instance, in the area I serve, New Brunswick, we have a large Hispanic population. So we look at individual, we can look at individual and tailor our care to those individuals. But if we actually look at what we can do in the community to actually help with that Hispanic population, that can change the health of that population and eventually change the health of New Brunswick.
So back up. What you're really saying is population health, if you break it down, what it really means is that you and your colleagues are responsible for the health of the larger community of New Brunswick, particularly the Hispanic population, because there are a unique set of health and medical related issues that they're experiencing. We're going to deal with those issues as opposed to one person in that community, which you're still concerned about, who you're still concerned about. It's everyone there?
Exactly. So you look at the population. We've tried the health system in the United States. As Mark said, it's a sick system. We deal greatly with, we do great acute care. Somebody comes to the hospital, we treat them greatly. We do that. What we miss is that piece when they leave the hospital or even before they come to the hospital. The program we run in New Brunswick, it's actually filling in the gap. The time a patient is discharged from the hospital to the time they are seen by a primary care provider. We fill in that gap.
What do?
Take care of the patient. The time somebody is discharged from the hospital to the time they actually see even their primary doctor or go to any of the clinic, it's an average of 30 to 45 days. And we know by studies that when a patient is discharged, the first 7 to 14 days is critical for them to be followed by a provider, any provider. So if a patient, especially low-income patients, do not have providers to see them, guess what? They come back to the hospital. For, instance, a patient who, I can give Efren as an example, who had a heart attack. We did thousands of dollars of procedure. We do a stent,
yes.
Put in a stent. To maintain the stent, you need X and Y medication. You need dual antiplatelet. If you cannot afford that, your $10,000 or your $20,000 of the procedure is to waste.
So stay on this.
Yes.
And I'll bring you all into this. In your particular case, you leave the hospital, you get the procedure. If you were on your own and no one came to check in on you or provide any proactive preventive care, what would have happened to you?
I will not be right here right now.
You don't believe?
I believe it with all my heart.
You'd be dead.
I'll be dead right now.
What did happen?
Well, what did happen was that before I was even discharged from the hospital, okay, Mr. Thomas here.
You were at the hospital. Go ahead.
And he talked to me about this program in which he was in contact with me. He gave me...
Excuse me, you had the heart attack?
Yes.
And you had a procedure?
Yeah, I had a stent put in. I had 2 stents put in.
And now Real Care had to...
be taken care of.
Got it, go ahead.
Okay, so once that was done, okay, and I started with this program, it was not just a visit or here are medications, do this and do that. No, it was informative, okay? He was actually teaching me how to take care of myself, okay? And by that kind of interaction that I was having with him, okay, I am able to be here today, okay?
But there are some who are watching right now, and even you know this as well, who are thinking, what about the VA?
Well, I fall in 2 different demographics, okay? I'm a retired military, plus I am Hispanic, okay? Now, to me, before I even started with the program, okay, for me, it was kind of hard to go to the VA due to the fact that my closest clinic that will have all the tools for me to be able to take care of would be in Lyons. I live in Edison.
How far away?
And that's 3.5 hours by train, okay?
So transportation becomes a huge issue.
That's right. Then that's one thing. And me being Hispanic, okay, we Hispanics, we don't really like to be involved with the healthcare system due to the fact that we are been instructed all our lives that the only thing doctors want is just money, okay? So because of that, okay, in those 2 demographics, I wasn't thinking until I was re-educated, okay, and this program did it for me.
I want you to jump in and respond. And by the way, describe your organization so people understand. You guys have been doing this, you folks have been doing this for a lot of years.
Absolutely.
And having a great impact on a lot of people.
Zufall Health is a community health center that is partially
Dover,
supported.
New Jersey.
In Dover, New Jersey is our headquarters, although we're in 6 counties in the northwest quadrant of the state at this point. And we receive some funding from the federal government, some funding from the state, and we are the primary care provider for basically the poor. So we're the family doctor to the poor in our community. And we've been looking at population health for years. The hospitals have
Before it was called that.
Before it was called that, it was called outreach and supportive services, enabling services. And we believe that we're going to try and keep you guys out of the hospital so that those tens of thousands of dollars don't have to be spent. Where we are focused is in the primary care and the preventive care.
How do you keep them out of the hospital?
So we are trying to deal with diabetes, heart disease, hypertension through focusing on nutrition. So we created in Morristown, New Jersey, a teaching kitchen. And we have a nutritionist who comes in from our local ShopRite and teaches our community. They can be our patients, they can be others in the community, moms on WIC, food stamps, whatever.
WIC is Women, Infant and Children.
It's a nutrition program for young families. And they are teaching the community members, the families, how to cook nutritious food on a budget. And we believe that those kinds of lessons up front, particularly for families with kids, is the way to reduce diabetes, reduce obesity, help prevent a lot of the illnesses. And while we have them in the teaching kitchen, we can talk about, are your kids immunized? You know, are you taking your statin drugs, Grandma? And we can really have a great impact on the community outside of the exam room. I think that what we've said here is we're moving health or wellness outside of the 15-minute exam room visit, because that's a very expensive and non-efficient way to provide care.
And outside the hospital?
And outside the hospital for sure.
Really?
Absolutely.
And are we trying to reduce the number of times people go to the emergency room?
Absolutely.
More and more.
It's a dreadful place to get non-emergent care.
And also, you have said, you told our producers that we need to be looking at health care and population health, if we're looking at serving the larger community, is also about looking at, and if I get this wrong, you'll tell me, quote unquote, environmental factors. Absolutely. Didn't you say, instead of just looking at issues of asthma from a clinical, purely clinical point of view, wait a minute. You said, well, what about if we got an air conditioner? Break that down, that air conditioner example.
So, I mean, health is about a lot more than just health care. And so someone that has asthma or someone that has congestive heart failure, an elderly person that keeps going back to the hospital because they're living in a small apartment that's overheated, that $200 air conditioner can go a long way to keeping them out of the hospital. We work in Camden with a lot of patients. We're very focused on sort of the sickest and most complex patients. A lot of them are homeless. And to be able to get someone into a safe, supportive housing environment can save hundreds of thousands of dollars for the person who is cycling in and out of the hospital in the emergency room.
Well, excuse me for interrupting.
Sure.
How do you get someone who's homeless, who has chronic health situations, a whole range of situations? You're saying healthcare is more than just about dealing with that person every time they go into the emergency room or doctor's visit, whatever it is. You're saying if you can get that person housing and a safe situation and there's air conditioning involved, you could potentially reduce a whole range. How do you do that?
So it's about coordinating beyond the traditional healthcare system. It's about looking at all of the different partners that are part of our broader social service system. So we're working with local housing providers. The homeless shelter is part of our coalition. So the Camden Coalition of Healthcare Providers is a community nonprofit that has as members Cooper, Lourdes Virtual Hospitals, as well as the local homeless shelter, community residents in Camden, and the whole range of providers, behavioral health, primary care, specialty care providers.
All those folks have to be involved.
All those folks are involved. They get together every month. They are collaborating on a whole host of initiatives. We're putting together a new supportive housing project that's focused on those highest users to try to get them off the streets.
Highest users of healthcare.
Highest users of the hospital.
And you're shaking your head because it sounds like more and more we're saying, we can no longer say, oh, healthcare. That's done by physicians, nurses, hospitals, people involved in healthcare. What I just heard you say was that that doesn't work anymore. No. All kinds of folks, including schools.
Correct.
That's right.
Everyone has to be involved.
Correct.
Talk about this.
Partnership, community partnership. I had a patient, I'll give you an example. I had a patient who comes to the hospital with seizure disorders. I saw him one time, the very first time I saw him, he's had 6 readmission. It comes in every 30 days.
So every 30 days he comes in to be readmitted to the hospital.
He gets readmitted for 2 days. He needs seizure medication. His medication is like $11. When he's in the hospital, we give him prescription for 30 days. He goes home, free prescription for 30 days. He goes home, he finishes the medication. He has no way of getting the other medication. 2 days later, comes back to the hospital. On the 32nd day, comes back to the hospital. We admitted him again for 2 days. This went on for like 6 months. Nobody picked that up.
And that's thousands of dollars each admission.
Thousands of dollars. I saw him, I gave him prescription for 3 months, 90 days, just to see. He came to the hospital to see me on the 92nd day. In the clinic, he had a seizure right there. So once his medication runs out, it's that. So for $11 a month, we can keep him out of the hospital.
And so so that is a good example of understanding that patient and what that particular patient needs to keep him out. But also, here's the other part. When you were home, how important were home visits?
Well, for me, it was...
Because Andrew came to your house.
Yeah, he did. He did. He came twice to my house.
Well, why was he coming to your house? What does that have to do with healthcare?
He did a follow-up, okay, after I came back, because he wanted to see the environment where, first, the environment where I was living at.
Right.
Okay. He wanted to see how I was interacting after I came out of the hospital with the family members of the house, and then he wanted to see my culture, how I used to take care of myself.
Did he look in your refrigerator?
No, he didn't, but he did see me eat. He did see me eat.
Hold on. What?
Yes, he did see me eat, because when he got home over to the house, I was actually sitting down to eat something, and he said, "You're not supposed to be eating that."
Did you really?
Yes.
Why is that healthcare?
Connecting with the patient, looking at the whole patient.
Because he's recovering from a heart attack.
Yes.
Go ahead, talk about this.
And firstly, we know that the transition from any one healthcare system, any one setting to another, is a critical condition. It's a critical time. You know, transitioning from the hospital to home. We discharge you on X medication. You go home, you were taking X medication, didn't tell anybody. We added that to you. You can continue that. So very critical time. So for certain diagnoses, acute myocardial infarction, congestive heart failure, we try to see the patients at home within 24, 48 hours. Go there, reconcile the medication. Look what medications they have. Do they have the old medication? Did we give them the right medication? In his case, it was actually great. It actually showed, population health or transitional care at its best. Because I went to his house, asked him, where are your medications? Oh, I don't have them. I went to the pharmacy, it's $241. I can't afford it.
$241
for one medication.
For one.
So you were like, I'm not taking it then.
He can't afford it.
I couldn't
and
afford
therefore,
it.
if you continued to not take that medication,
I would not be here.
You would not be.
His stent will have closed because he has a stent and he has dual antiplatelet. So I said, how much money do you have? I think he had like $41.
Okay, because it wasn't covered because it was out of network, as I understand it.
It was out of network. He had just moved from Florida.
Okay, go ahead.
And this is also the interesting thing. He actually qualifies for insurance. At that time, I think he qualified for Medicaid. But again, it takes 30 to 45 days for you to get the coverage.
So you're not going to get the medication. So what did you do? Short version. What did you do?
We actually spoke to his cardiologist if we can change it to another brand, same, generic brand that is cheaper. Then we provided him with the medication until the insurance.
Which I was told was cheaper.
Yes.
Obviously, we're thrilled that you got the treatment and the care that you got. But I'm thinking about all the people who, A, don't know about such an effort and don't get that kind of care.
Moving the care to the home, to looking at the environment, to doing preventive activity is terrific. The real question is, how do you pay for it? There's, we know that by getting him $240 worth of medication, we can save tens of thousands. But who in the system is going to pay for that? Where we, as a health center, get paid is for those 15-minute, 20-minute visits. So when we attempt to run a nutrition class, or we have 2 clinical pharmacists on our staff who are counseling patients about their meds, how do we pay for that service? We're out scrambling for grants, but really it should be a way for the insurers and for Medicaid and Medicare, and they're starting to incentivize the providers to do these programs, to pay for those programs, to pay for all of the care and the care coordination that we now have to do.
So the federal government actually saw that as a problem. So now we have bundled payments. You come in for congestive heart failure, you're responsible for that patient. If the patient is readmitted within 30 days, you're penalized. So now you have to do everything to keep that patient out of the hospital.
But here's the question. Everything you're talking about here, to me, as a layperson, it sounds like you're talking about more health care, and I'm sitting there saying that's got to cost more.
No, it's really different health care, and I think that's what everyone has been describing. We've got a lot of people in our hospitals that don't need to be there, and we're spending a lot of money on them. And if we make investments in things like coming to home, people's homes, making sure that their medicine's reconciled, we can keep them out of the hospital, and that can save a lot of money. We do this in Camden, and we actually have some financial arrangements that allow for this to happen. So
example?
accountable care organizations are something
Accountable care organizations. That's what healthcare needs, more acronyms and jargon. But go ahead.
So it's the idea that a group of providers, and for us it's really this broader coalition that I described before, takes responsibility for the health and the cost of all the care for a population. If we can do things that improve their overall health and reduces the cost, then some of that money can come back to the organization. So it creates financial incentives to do the little things like going to the home, making sure the person has the right medication, that they're filling that prescription to stay out of the hospital.
Here's the other question. How much of this, everything we're talking about, population health, outreach to the community, also using technology is a big part of this, right? How much of this depends upon patients having a different mentality and a different approach to their own health care?
Well, it does help, okay? Like I said, me being a Hispanic, all our life, they're used to...
Yeah, I'm sorry for interrupting, because you made this whole... listen, I was going to challenge you, but you happen to be Hispanic, I'm not. You were saying Hispanics view this. I'm like, that's a pretty broad statement. You're generalizing, but like I said, you're Hispanic, I'm not. But the point I'm making is, if even some of that is true, well, doesn't it then require that those in the Hispanic community start looking at the healthcare world differently?
Yes, it does. And one of the things that, for example, the program that Mr. Thomas helps us with is that it teaches us. And once you're taught...
Taught what?
How to better yourself, how to manage your own health care.
Eating differently?
Eating differently.
How about the medication?
Where to get the medication.
How about exercise? Let me ask you something. Do you have a different...
Yes, I do.
The word is on the street that you have a different workout routine.
Yes, I do. I actually, I live 3.5 miles away from where I work at. And I don't use public transportation or anything. I actually cycle 7 miles a day, 7 days a week.
And you did not before?
Before, I did not walk, not from here to the front lobby.
It was about 40 pounds
40 pounds?
overweight.
You've dropped...
I lost about 40 pounds.
You dropped 40 pounds?
Yes. When I went into the hospital with the heart attack, I was weighing 268 pounds. I weigh 203 pounds at this moment.
What are the implications of what we just heard to your friend's health?
Significant, very significant.
Particularly as it relates to his heart.
Oh,
or
yeah,
his
absolutely,
cardio health.
absolutely significant.
Well, I can tell you exactly what my cardiologist told me last Tuesday. I had a visit with him. He said, I lost 13% of fat. I gained 17% of muscle mass, okay? My cholesterol went down from a 336 at the beginning to a 114.
That's extraordinary.
And all this happened because I just followed exactly what they told me in this program, okay? And the thing is, it's not only staying with me. I have a roommate that he is type 2 diabetic, okay? He also is a cardiac patient, and the nutrition that I do at the house is instilled in him, and I get on him all the time when he has his visits to his
You're helping
cardiologist.
him.
Yep.
It's become an
Help
ambassador.
us on this. Go ahead.
You know, we need to get your kids and, you know, my grandkids. We need to get those folks really engaged in the exercise, in the biking, in the healthy foods before they get to that stage of type 2 diabetes.
Is that part of population health?
And it is absolutely a part. And so
Describe
we try to educate the parents. You know, parents get very upset when the kid's in the exam room and you say your child is obese. I mean,
do they get upset?
Oh my goodness, and I mean, in some cultures that just can't imagine that. The child is chubby and that's a good thing. But in fact, we need to educate the parents that chubby is not necessarily a good thing. And we try and talk to them and get them involved in exercise, in in learning how to
Eating differently.
eat differently, and learning that it's affordable to eat differently, because that is an issue. People will be more likely to eat well and take their medication if they can afford it, if it's not a question of pay the rent or buy your medication.
Why don't you, I see you want to jump in. We'll have this conversation off air because half hour goes by quickly, even in public broadcasting. I want to thank all of you for talking about the importance of population health, but most importantly, I want to thank you for your service to our country and wish you nothing but the best.
The preceding program has been a production of the Caucus Educational Corporation, celebrating over 25 years of broadcast excellence, and 13 for WNET, NJTV, and WHYY. Funding for this edition of Caucus New Jersey has been provided by the Robert Wood Johnson Foundation, Wells Fargo, Berkeley College, PSE&G, MD Advantage Insurance Company of New Jersey, the Mental Health Association in New Jersey, and by Steve and Elaine Pozicki. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. Caucus New Jersey has been produced in partnership with TriStar Studios.
Think of 5 people in your life, including yourself. At least one is struggling with a mental health condition. And heroin and prescription drug overdoses are among the leading causes of accidental death in the United States. The Mental Health Association in New Jersey is a leader in advocacy, training, and services for behavioral health, including mental health and substance use disorders. The challenges are real, but recovery is possible.